Welcome to section 32 of the Falcon Physician Reviews Anatomy Online component. Now we're going to discuss the pelvic nerves and the pelvic vessels. Let's start with a question. A 68-year-old man complains of severe and painful urination. A CT scan and biopsy reveal an enlarged and cancerous prostate gland. He underwent radiation therapy and a prostatectomy. Post-operatively, he suffers from urinary incontinence due to a paralysis of the external urethral sphincter. Which nerve must have been injured during the operation? What you're looking for in this question is the pudendal nerve. The pudendal nerve is going to be an important and often tested nerve in almost every exam that you'll take, including the USMLE. The pudendal nerve is going to be from S2, 3, and 4, as we'll see momentarily, and it will supply all of the somatic stuff that's in the perineum. Pudendal means to be ashamed. The key to this question is that the external urethral sphincter is voluntary and somatic, and the pudendal nerve is voluntary and somatic, as is the superior gluteal and inferior gluteal, whereas the pelvic and sacral splanchnics are visceral. However, the pudendal nerve is the only one that's going towards the perineum, whereas the superior and inferior gluteal nerves stay posteriorly in the gluteal region. We've talked at length about the pelvis, and now we want to take the vessels out of the pelvis. We've talked about the sciatic nerve. Now we want to look more closely at the branches that are going to be going into the perineum. Here in this view you can see a nice greater sciatic foramen, which is covering now the piriformis muscle. Then you can see the lesser sciatic foramen, which has the tendon of the obturator internus coming through it. And what you end up with is the structures that come above and below piriformis through the greater sciatic notch. Above piriformis you have things like the superior gluteal nerve, arteries, and veins. Below piriformis you have the inferior gluteal nerves, arteries, and veins. Also the sciatic nerve and the internal pudendal veins and arteries, as well as the pudendal nerve. Remember that the pudendal nerve is running in the neurovascular bundle with the internal pudendal vessels. Out of the lesser sciatic notch you have the obturator internus and the internal pudendal vein, arteries, and the pudendal nerve, which will then go back underneath the sacrotuberous ligament, and that's how it gets from the pelvis into the perineum. Once it crosses under that sacrotuberous ligament, it is now in the lesser sciatic foramen and in the perineum. Now we'll move on to look at the sacral plexus. We're only going to work on this momentarily, though, because we've covered a lot of this in the lower limb module. So what we're really interested in looking at here is this pudendal nerve, which will run from S2, 3, and 4 motor roots. Follow it up and make sure that you can see that it's coming off of the S2, 3, and 4 ventral rami. The thing not to confuse it with will be those things that are coming off as pelvic splanchnics. These are the parasympathetic nerves coming off the same root levels off the ventral rami, but these will be going to pelvic viscera and hindgut parasympathetics. I remember pelvic splanchnics has a P for parasympathetics. In situ, you can see the same things that we've seen earlier before, and now you can see that pudendal nerve, S2, 3, and 4, going through the greater sciatic foramina towards the shameful areas. And here, staying inside the pelvis, are going to be the pelvic splanchnics, S2, 3, and 4, parasympathetics. The pudendal nerve is somatic, the pelvic splanchnics are visceral. Off to the side, running along the edge of the sacrum, is our sympathetic chain. Coming from those and going to viscera are going to be the sacral splanchnics. Those are sympathetic. S for sacral splanchnics, S for sympathetic. Notice how there's still gray rami communicans getting onto the nerves of the sciatic and other somatic nerves to carry out to the vessels in the limb. As far as autonomics, we left off in the abdomen with the superior hypogastric plexus at the bifurcation of the aorta. That superior hypogastric plexus will drop down into the pelvis as two condensations known as the superior or hypogastric nerves. So the hypogastric nerve will be sympathetics, and they'll be combined by the sacral splanchnics coming off of the chain, and they'll then come together with some parasympathetics known as the pelvic splanchnics. So what we end up with in the superior hypogastric plexus is some lumbar splanchnics and some afferents, of course. And then in the inferior hypogastric plexus, we end up with parasympathetic pelvic splanchnics off S2, 3, and 4, hypogastric nerves, which are sympathetic, and sacral splanchnics off the chain, which are also sympathetic. So 3 components. All of these will come together and make multiple plexuses around the organs that they're going to innervate. So from this inferior hypogastric plexus, there's going to be a prostatic plexus, a rectal plexus, a vesicular plexus, an ovarian plexus if it's female, and so on and so on. Let's go to another question. A 34-year-old pregnant woman is prepared in the hospital for delivery. The gynecologist decides to perform a pudendal nerve block using a transvaginal approach. Which bony structure will the physician use as a landmark for this injection? Hopefully, by this time, you'll know that the ischial spine will be the target that they'll be aiming for, because it's a palpable bony prominence through vaginal exam, and it's an easily aimed at target through the ischial-anal fossa, which we'll discuss a little bit later. So let's follow the course of this pudendal nerve and make sure that everybody understands its course. The purple line shows the attachment of the levator ani and pelvic diaphragm. And there's no exit or egress from the true pelvic cavity through that lesser sciatic foramen. So the pudendal nerve needs to go out through the greater sciatic foramen in order to get access to the lesser sciatic foramen. And it's only by coming back through the lesser sciatic foramen that it enters the perineum and gets itself outside of the pelvic diaphragm. Once it's outside the pelvic diaphragm, it will supply branches to the external anal sphincter. It will supply branches to the posterior labia or scrotum, and it will supply motor branches to the things within the deep pouch, like the external urethral sphincter, and some of the erectile tissues that we're going to talk about later. After giving off those last motor branches, it becomes sensory only to the dorsal surfaces of the penis or clitoris, depending on whether it's male or female. So that ischial spine is a good target for innervation and obstetrical applied anesthetics, because it's easily palpable, and you can see how getting an anesthetic just close to that spine would diffuse across that pudendal nerve and knock out both rectal and inferior labial sensation. There's a few of the other structures that we've already talked about, and you can see the tendinous arch for the attachment of that levator ani muscle. So in words, you can see here what the pudendal nerve is going to be involved in. It is primary somatic. It's going to be involved in defecation for the external anal sphincter, micturition for the external urethral sphincter, and copulation for the muscles of the external genitalia. It leaves the pelvis through the greater sciatic foramen. It enters the pudendal canal via the lesser sciatic foramen, where it gets into the perineum, and it has branches to the inferior rectal area for the anal sphincter, which will be in charge of the anal wink reflex that you'll use clinically to see if there's an S5 clearance. Also, there'll be a posterior labial or scrotal branch that will be sensory, and then perineal branches, which will be inside the perineal membrane, also known as the UG diaphragm. These branches will go around to the erectile tissues, and then it will become sensory to the dorsal nerve of the penis or clitoris. You can see a pudendal nerve block that's being applied by digital palpation of the vaginal canal, which you can palpate the ischial spine, and then head the needle through the ischial-anal fat in the ischial-anal fossa and aim for just getting near that pudendal nerve. Let's try another question. A 65-year-old male with a history of heavy smoking and hypercholesteremia is diagnosed with a severe atherosclerosis affecting many of the arteries of his body. During history taking, he complains of impotence, occlusion of which artery may have caused this condition. Hopefully you'll remember that the internal pudendal artery is going to come around and supply the external genitalia along with the pudendal nerve. That internal pudendal artery will give off a branch that will be the deep artery of the penis or clitoris, in this case, of course, penis. And this is affected by all sorts of diseases and drugs which can cause a functional impotence. Now we'll move on to the blood supply of the pelvis and perineum. We've talked at length about the common iliac having an external and internal iliac, and then the internal iliacs will have more of the variable branching patterns in almost every major artery in the body. It's going to originate at the level of the SI joint from the common iliac and then drop into the true pelvis by dropping into the pelvic brim. Typically has 9 or 10 branches depending on whether you're male or female. It will have 2 major divisions, a posterior, which has 3 branches, and an anterior, which has 6 or 7 branches. All of the anterior branches are the ones that will come off to the viscera, and then there'll be a few that leave the pelvis, and all of the posterior divisions will actually go to the pelvic walls or different regions outside of the pelvis. So the posterior division has 3 of what I would call a parietal branch, meaning it goes to the pelvic wall or outside the true pelvis. 2 to the pelvic wall, which will be an iliolumbar that goes up and out of the pelvis, and then a lateral sacral, which will disappear into the ventral foramina of the sacrum. The 3rd branch will be one to the lower limb, which will be the superior gluteal. And typically, remember, that exits between the lumbosacral trunk and S1. The anterior division is a little bit more variable, but it has also 3 parietal branches. 1 is an obturator through the obturator canal. 2 is the internal pudendal, which we've discussed going through greater sciatic foramina. And 3 is the inferior gluteal, which will also go below piriformis in the greater sciatic foramina. The rest of the vessels off the anterior division are going to viscera and staying in the pelvis. The only thing that actually leaves the pelvis is the obliterated portion of the umbilical, which is running on the anterior abdominal wall. Before it goes into the anterior abdominal wall, it will give off bladder branches to the top of the bladder. Then there'll be some inferior vesicular branches, some middle rectal branches, and often a uterine branch if there's a female. I say often because, of course, that can be tied off if there's a hysterectomy. And that's going to be an important clinical correlation about how you can avoid causing damage to nearby structures during hysterectomy. This is just a slide that's showing some of the branching patterns to these vessels. And I would suggest that you take a few moments to look at that if you need to remind yourself, but we've talked about many of them in the lower limb already. This is an actual dissection picture that shows many of these vessels as well, and just some of the variation that you can expect. Notice how the superior and inferior gluteal in this specimen come off of the posterior division instead of coming off the anterior division as the typical or classical division would be. Also notice the umbilical giving off superior vesicular and then being closed off to the rest of the injected materials that have been put in through here. That concludes section 32. The next section will deal with the external genitalia.